Kim from the University of Seoul, and he will report about a very interesting combination that is nanomedicine and surgery. So welcome very much.
Thank you for giving me the opportunity to speak in front of today. The topic of my presentation is application of nanomedicine in surgery for thoracic oncology. In 2012, series data shows that the estimated cancer patients older than 65 years old, almost half. In particular, lung cancer, almost 70% of patients older than 65 years old. Since world population is aging, many surgeons are now facing with growing number of patients with resectable cancer who are aged and therefore have limited cardiopulmonary function or extensive comorbidities. Therefore, in those patients, personalized surgical treatments such as minimally invasive surgical approach should be needed. In the lung cancer surgery, the traditional method for patients with small-sized lung cancer, wide open thoracotomy, and removal large part of normal lung, including small-sized lung tumor. In those patients, the patient suffers from the dyspnea and wound pain for the rest of his life. The current trend for the surgical treatment of lung cancer is minimal incision using the thoracoscopic approach and minimal resection. Only remove the tumor with leaving the normal lung tissue as much as possible to achieve better quality of life after surgery. So we launched minimal incision and minimal resection operation for the lung cancer. Minimal incision achieved by a few millimeter incision or no incision in the near future. Minimal resection can be achieved by central lymph node navigation surgery or tumor image guide surgery in the near future. Today I will talk about the central lymph node navigation surgery in lung cancer. Central lymph node is the first lymph node from the primary tumor. So before operation, the radioisotope or the blue dye was injected at peritumoral region. And then, radioisotope technique or by our own eyes, we can detect a central lymph node and dissect it and send to the present pathology department. If there is no tumor on the central lymph node, most likely distal lymph node has no metastasis. It's very useful to avoid unnecessary lymph node dissection of non-metastatic lymph nodes. So it's quite useful in the breast cancer and melanoma to avoid unnecessary lymph node dissection. It causes the severe complication after surgery, such as lymphedema like this. So this central concept is now standard treatment of early stage of breast cancer or melanoma. Nowadays, this concept has expanded to other malignancies, such as lung cancer and esophageal cancer. However, these cancers have located in the internal organ of which lymphatic system have three-dimensional distribution and complex structures. So it is difficult to detect sentinel lymph node in those cancers by using existing techniques such as blue dye or radioisotope technique. So we need a new technology to detect sentinel lymph node in those kind of cancer. We developed a new tracer, technetium neomonocyl serum albumin, as a new agent for sentinel lymph node mapping. Neomonocyl serum albumin is originally made from human serum albumin. Human serum albumin passes through the lymphatic system without delay in lymph node. However, MSA have the property of faster migration of the lymphatics with delay in sentinel lymph node, because it can be uptaken by the macrophage in the lymph node. So we did clinical trial of sentinel lymph node by using this material in lung cancer patients. Before operation, we insert this material peritumoral region under CT guidance or bronchoscopic guidance. And then SPECT lymphoscintigram was taken 30 minutes after injection. And during operation, we dissect all the lymph nodes to measure their radioactivities on the back table. You can see that this is the structured lymph node. It is black pigmented, so blue dye technique cannot be applied this kind of lymph node. After dissecting those lymph nodes, and the radioactivity of these lymph nodes was measured on the back table. If their radioactivity shows higher than the normal lymph node, it is considered as a sentinel lymph node. Here you can see the higher number. So the radioactive technique is quite better than the blue light technique in lung cancer surgery. However, the radioactivity of the primary tumor is so strong, so it masks the radioactivity of the sentinel lymph node is masked by primary tumor's radioactivities. So it is difficult to detect sentinel lymph node in vivo status. We call that shine-through effect. So 2009, multi-center trial of in vivo detection of the sentinel lymph node shows disappointing result. So in 2009, the near-infrared-based sentinel lymph node identification was introduced to enable real-time visualization of sentinel lymph node and lymphatics. You can see two cameras. This is a white light camera and the fluorescence camera. By merging these two images, you can see the sentinel lymph node on the porcine lung. So we developed thoracotomy version of intraoperative color and fluorescence imaging system for sentinel lymph node detection. You can see the experimental view, and this is the control monitor. This is the white light image and NIR image. This is a combined image. After injecting the fluorophore, in this experiment we used ICG, indocyanine queen. After several minutes, we can see the sentinel lymph node here. This is the primary region of the lung. And we can dissect the sentinel lymph node, watching the monitor, and resect it. Again, at the long parenchyma, we injected the ICG. The NI image, we can see the contrast here, but is pseudo-colored as a green. And merged image, we can see the lymphatics in the primary region. On the other side, we can see the sentinel lymph node. And then we developed thoracoscopic version of this imaging system. So this image comes from the white light camera, and this image comes from the NIR camera. And we can achieve the merged image from this system. And also we try to test MSA as a real-time visualization of central lymph node. So the MSA was reacted with ICG, and the fluorescence intensity shows higher than the in the ICG MSA than ICG. So using this new material and our thoracoscopy system, we tried experiment. So after injection through the skin at the long parenchyma, you can see the primary injection site here. And then several minutes, you can see the central lymph node here. So we can resect, watching the monitor, and put it out from the body. And it was sent to the pathology department. So the other experiment shows the same result. So nowadays, we are trying to developing liposome ICG for developing optimal traces for real-time specific targeting at central lymph node and tumor itself. And liposome is, we think, relatively safe in clinical field. So the liposome ICG shows higher fluorescence intensity than the free ICG in left eye. So in conclusion, image-guided surgery based on central lymph node or tumor can be a decision maker for surgical extent. Diagnosis achieved by intraoperative imaging. Therapeutics achieved by surgical removal. For the surgeons, it is diagnosis. It is easier to be applied in real clinical field. This is our research team. Thank you for your attention.
Yeah, thanks a lot for this very nice symbiosis of surgery and nanomedicine. Are there questions from the audience? I may have one. Would it be possible to combine that with, targeting ligands that would specifically target cancer cells so that you would be more easily seeing whether you have still residual tumor cells when you do the resection of the primary tumors?
Yes, that is our final goal, to resection margin of the tumor by the specific targeting. But until now, it is impossible because we cannot find any specific targeting for the tumor itself. So that is our goal.
Well, it's said, at least that's the concept of a company called Abraxas, and that albumin is taken up at least by certain kinds of tumors preferentially. I think they do a lot of studies in pancreatic cancer, and as albumin is your carrier, there could be a chance that this could be used, just as in. Otherwise, no questions. Then we move on. Thanks a lot again first. Then it's my pleasure to welcome